Good afternoon, everyone. Welcome to AIOS. My study is on comparison of phakic IOLs size and postoperative vault height with predictive formulas and anterior segment ocular coherence tomography. So, phakic IOLs are the IOLs implanted in phakic eyes for correction of refractive errors where the corneal-based procedures are contraindicated. But with these lenses, the sizing always remains a challenge because the white-to-white correlation to sulcus is imperfect, and relative to the limbus, the sulcus is on average 0.42 mm longer than the white-to-white, and the sulcus to sulcus distance is variable in a given eye. So can prediction formulas on AS4CT will help us to overcome this challenge. So apart from the anterior chamber depth and white to white, there are different parameters in the anterior segment. Here we could see that the distance between the scleral spur to scleral spur, which is known as anterior chamber width, and the distance between the angle recess to angle recess, correcting the distance to the crystalline lens is known as crystalline lens raise. So based on all these parameters, the predictive formulas were formed, like NK and KS formula, which are there on AS4CT, which will predict the size of the ICL and the postoperative vault out for that given eye of the patient. So a total of 40 eyes underwent phakic IOL implantation, 20 eyes IPCL and 20 eyes ICL. It's a retrospective study where the preoperative AS4CT was done to document the predicted ICL size and postoperative vault height through NK and KS formula. All patients white to white was taken from digital calipers by a single surgeon. IOLMaster 700 and pentacam was also done. Postoperative vault height was calculated at the end of 1 month. So these are the inclusion and exclusion criteria. So coming to the results, the baseline parameters of spherical equivalent and K readings were comparable in between these two groups. So coming to the white to white parameters, the white to white measured by the digital caliper and by the white to white measurement of the pentacam were almost similar, but whereas the white to white measurement by IOLMaster 700 has overestimated compared to the other two. Coming to the size parameters, the size of the ICL that is calculated by the manufacturer was more compared to the NK and KS formulas which was predicted on the ASOCT, but there was no statistical significance. So here we could see in each and every patient, the NK and KS formula has predicted the smaller ICL size than the actual nomogram. But in IPCL, we know that it comes in a different 0.25 increments, but the AS4CT predictor formulas can give only 4 different sizes, so the exact comparison could not be made. But in most of the patients also, in IPCL group also, the prediction formulas tend to select a smaller size than the actual nomogram. So coming to the vault height, the post-operative vault calculated at the end of 1 month was higher than compared to the NK and KS predicted post-operative vault height. So 2 eyes in group A and 4 eyes in group B has higher vault height, more than 1000, and 2 eyes in group B had lesser vault height. So when these patients were analyzed separately, we could see that in patients where the post-operative vault height was more, the NK and KS formula has predicted one size lesser. Whereas in patients with a lesser vault height, the NK and KS formula has predicted one side more. So in higher vault eyes, NK and KS formula preoperatively predicted lesser lens size compared to the implanted size, and in lower vault height, NK and KS formula preoperatively predicted the higher lens size compared to the implanted side. The crystalline lens size and postoperative vault height has a strong negative correlation. So the limitations were a retrospective nature, small sample size. So a prospective multi-center clinical trial is necessary. The pentacam device was closest to digital calipers in white-to-white measurements. In addition to the traditional methods referring to the NK and KS formulas can lead to a more accurate and predictable outcomes, mostly in the borderline cases and when to plan the other eye. Conducting more prospective studies with a large number of patients can help improve the formulas to develop a better algorithm. Thank you.
Thank you. It's a very important study actually because so many new formulas, ASOST based formulas have now come in to calculate the vault. So I just wanted to ask, did you rotate the ICL or was it a toric ICL in the cases where you had vault more than 1000 or did you exchange that ICL? What was the management? You had 2 cases, right?
We rotated in one patient where the both eyes has done, but still it was the same.
Okay. All right. And the other eye, was it exchanged or it was just monitored? The IOP was okay?
IOP was okay, it was monitored.
Okay. And NK3 was used in our study because NK formula has also undergone so many
So many
changes.
changes.
Yes.
But the present which was there in the cassia.
Okay.
The-
Thank you.